organizers for allowing us to give this course again this year. And I'm going to the last topic where I'm going to talk about a common complication of myopia, retinal detachments, as well as a little bit about macular buckles and our experience with it. These are my financial interests. So I think we all know retinal detachment is common in high myopes, and the prevalence of retinal detachment is much higher, reported anywhere between 5-fold to 39-fold in various publications. And we know the yearly incidence of retinal detachments in myopes increases with increasing myopia. And this presents a problem because there's an increasing global prevalence of retinal detachment with increasing myopia. We know the pathology is related to the more peripheral vitreous, which is more adherent, as well as the increased shear forces and stress between the retina and the vitreous in high myopes, as well as the increased prevalence of peripheral retinal degeneration and thinning in high myopes. We also know that preoperative myopia is a risk factor for retinal detachment after cataract surgery, and these highly myopic eyes tend to have more complex breaks with multiple lattice breaks as well as giant retinal tears. So do we know if the outcomes of retinal detachment is worse in high myopia? I think the data in high myopia is a little bit limited in large case series, but in general, in a few of these studies, again, they are older ones, which reported single operation success rate of below 90%, closer to 80 to 85 in many of these high myopes. There was one study which compared and found no difference between the outcomes of myopes or non-high myopes. However, in these pediatric patients, they found a difference. In our own data, we didn't find any difference between the highly myopic eyes and the non-myopic eyes in terms of first operation success rate or overall anatomical success rate, but we did note that a high proportion, 3/4 of our highly myopic eyes, had combined rather than primary vitrectomy as the treatment of choice. When we looked at pediatric retinal detachments, and we do have quite a number of high myopes in children, we did find that half our population with retinal detachment in children had myopia as the main risk factor, and of those, 70% had high myopia. And these high myopic patients were more likely to have higher multiple breaks, higher rates of proliferative vitreal retinopathy, as well as a poorer primary as well as final anatomical success rate. What are the technical considerations? I think you're dealing with an instrumentation in a longer eye, thinner sclera, more skytic vitreous and adherent posterior hyaloid. There is a higher occurrence of multiple breaks that you need to address, and there is a slightly lower first operation anatomical success rate when you look at the overall literature, as well as a slightly higher prevalence of proliferative vitreal retinopathy. So scleral buckles tend to be very useful because these myopic patients have detachments at a younger age, where they may not be complete posterior vitreous detachment. In these highly myopic eyes, we tend to prefer an encircling band on top of just a segmental tire. You do need to note the thinner sclera has a higher risk of perforation. You need to ensure there's adequate positioning in these larger eyes and ensure adequate indent that covers all the breaks. There was a study that looked at 4,000 scleral buckle patients and found the primary success rate was lowest in high myopes with myopia of more than 8 diopters. We know primary vitrectomy is increasingly being used to treat retinal detachments, and it is increasingly useful with our small gauge vitrectomy and our better wide, ultra wide viewing systems. You need to ensure you have meticulous shaving of the vitreous base, especially a lot of these younger phakic patients. It's useful to use adjuvants to stain the vitreous, and I think you need to ensure there's adequate post-operative positioning, particularly in the inferior pathology. I think a myopic primary retinal detachment would be treated no different from any other retinal detachment. I prefer to use triamcinolone to stain the vitreous to ensure I have relative or adequate clearance. And often, if the macula is off and it's a very anterior break, it's useful to use perfluorocarbon to flatten the retina and the macula. So combined buccal vitrectomy is still used in some places, although the prevalence of such surgery is decreasing. We find it useful still in some of these phakic cases with extensive lattice or multiple breaks or with pre-existing proliferative vitreal retinopathy, and we tend to use a 360 encircling band. There is some older data that suggests combined surgery may be more effective than plain surgery in myopic eyes, but again, I think the advantages of small gauge vitrectomy and better viewing systems may have negated a lot of this difference if you look at primary vitrectomy done today, which is why the more recent publications no longer find such a big difference. This is my own preference to use an 360 encircling band, and then proceed with the posterior vitreous detachment and the rest of the vitreous shaving as per normal. So I think Adrian talked a little bit about the evolution of myopic tractional maculopathy, and one of the areas that vitrectomy does not address in these patients is the anterior posterior traction. And we know there is a combination of forces that results in myopic tractional maculopathy. This discussion of how to grade both the tangential and perpendicular evolution of disease is again presented here. And in cases where the anterior, posterior, or perpendicular evolution is, we think, the main driving force, that would be useful to add a macular buckle or use it as primary therapy. And another thing that we tend to do with this highly myopic macular holes with detachment is, especially when you don't have a primary macular buckle, is to add on a second substance or substrate or scaffold to help you bridge the gap. We often are able to use ILM, although sometimes in prior failed surgery, you need to think of alternatives such as lens capsule, autologous blood, or amniotic membrane. You can also use full thickness retina. This is an example of a macular hole retinal detachment where the ILM flap was used to cover or bridge the gap at the macular hole, and that would increase your chance of not so much redetachment, but macular hole closure after these surgeries. There are cases where there's no ILM available, and there is increasing data that using autologous retinal transplant may be beneficial, but we need a better understanding if this really improves the central vision, because there's little evidence that there's actually synaptic formation that results from these transplanted retinal tissue, and it may just be a physical bridging gap. This is an example of a macular hole retinal detachment where you can, the retina is already detached, so it's quite easy to harvest a free piece of a full thickness retina, and that can be easily brought over to the macular hole. That can be done under gas in this case or under perfluorine. Both has its pros and disadvantages. And of course, you need to laser that break that you've created adjugenically, and in this case, silicone oil was used as a tamponade. So again, back to the anterior posterior tractional forces and axial elongation. I think Kyoko mentioned earlier that you really don't get schisis except within the borders of the stathloma. So addressing this would seem to be a logical and kind of like a reasonable option. So you can do that in two ways. The first way, a traditional method that used to be done was scleral imbrication, where you use sutures to bring sclera together to shorten the anterior posterior distance, but that may sometimes be asymmetrical and result in folding. You can also use an external device to indent the macula, which is a macular buckle, which creates an effect perhaps not unsimilar from our other encircling sclera buckles. There are many macular buckles available. Most essentially, it's an external device designed to indent the macula and relieve axial traction. There are few that are commercially available now, and our experience is with the AGL custom macular buckle, which has a wealth of data published by Barbara Paroloni. So again, it's going to be useful in stage 3A or 4A. And when there is tangential traction or macular hole, then you should combine this with a vitrectomy. So the outcomes does suggest that macular buckle is pretty successful anatomically. And in this paper from their group, they did find that the anatomical closure rate of the macular pathology was much, much higher than with macular buckles than with primary vitrectomy alone. They've also looked at the long-term follow-up to see if the macular buckles result in more long-term atrophy, which is a concern in these myopic eyes. And in this case control study, they did not find a difference in the progression of myopic macular atrophy. In fact, it was mildly higher in the control group. This is a case example that we have. If you're going to start this, it may make sense to try it on a recalcitrant case, a case that has poorer vision, that will have less likely to suffer from complications, because I do think there is a slight learning curve. This is a 44-year-old Chinese lady, minus 10 diopters, presenting with hand motion macular detachment. had first surgery, redetached, was given a fluid gas exchange, this time remained attached with a persistent macular hole, but later the macular hole caused the macular redetachment again. This time was given silicone oil, and after removal of silicone oil, redetached. A second silicone oil procedure was performed, and unfortunately, even with oil, she redetached. And she came to seek a second opinion with myself. And you can see here, it was detached in spite of all, and that's because there was a very pointed staphyloма where, unless he was posturing face down, there was inadequate tamponade. And this is the procedure which was combined here, since there's a macular hole as well. This is positioning the macular buccal, which is kind of customized according to the axial length. But we know in the earlier talk that all staphylomas and shapes of these eyes are quite different. So even though it's customized for axial length, it will not always position exactly where you want it. You can just use a contact lens with the illumination chandelier in order to identify where the buccal is, but I find that having an IOCT really helps you make sure that your indent is exactly where the remnant macular hole is. In here, we did add on an amniotic membrane transplant since this patient already had multiple 4 or 5 surgeries, and eventually that was put in, placed over the where the macular hole was, and gas tamponade was used. So this patient did fairly well. You can see there's a nice indent, which has removed or obliterated or reversed the staphyloma, and there's closure of the macular hole as well as reattachment of the macula. So in conclusion, retinal detachment in high myopes may have a higher risk of failure, and circling band may be useful in some patients where you worry about PVR, although primary vitrectomy success rates are now much better than in the past. I think in myopic macular holes, you need to consider whether you need material with retinal detachment, whether bridging the gap with tissue is going to be useful. And with cases with excess axial traction, I think macular buccals can relieve that traction and improve anatomical outcomes. Thank you. So I think we're a little bit over time. There's the opening session if those who need to attend, but we don't have a session here, so if there's anybody who wants to ask a couple questions, they can. If not, thank you very much for all my fellow speakers. Thank you for being a good audience, and hope to see you again next year. Thank you.